Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Surveillance Strategies for Success Part 3 call. Please note that all lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Deb Smith. Ms. Smith, the floor is yours.
Thank you, Laura. And good afternoon, everyone. Thank you for joining us today for a review of the NHSN 2016 annual training. My name is Deb Smith, and I'm one of the improvement consultants working for VHQC, who is the quality improvement organization for both Maryland and Virginia. Just a few housekeeping items. This call is being recorded, as were the previous calls in this series, and they're shared through the VHQC online community, and they're also shared by the stakeholders involved with planning this webinar. All of your lines are on mute, as Laura told you, so we will have a question and answer period at the conclusion of the presentation. You'll be given instructions at that time on how to ask your question. However, please use the chat box to the right of the screen and ask questions and make comments during the presentation. Sarah Lineberger from the Virginia Department of Health and Karen McGoldrick from Centera Lee will be monitoring the chat box today. Any questions that are logged in there, of course, that we don't get to during the call, we will send out after the presentation. I want to once again thank our stakeholders who partner with us and make a great team in Virginia working on quality improvement. We're so fortunate to have them. So I want to recognize Virginia APIC and the Virginia Department of Health for their continued support of infection prevention activities in Virginia and sharing all of their knowledge, tools, and resources beyond the state of Virginia to our Maryland providers. Today's speakers are myself and Carol Whalen. Carol Whalen is an improvement consultant working with VHQC and assisting the Maryland providers. I'll begin with an overview of CLABSI training, and Carol will follow with an overview of CAUTI training. So our goals for today are going to be CLABSI, CAUTI, and a little bit of other. Originally, this webinar was slated to cover CLABSI, CAUTI, Lab ID, and SSI highlights from 2016 NHSN training. We had way too much material. We still have a lot of material, so we decided to break it out into another session. So today, Carol and I will be covering CLABSI and CAUTI, and then we're adding a part 4 that will cover Lab ID and SSI, and we'll hold that in 2 weeks on April 22nd from noon to 1. You'll be getting a registration link. This will probably be sent out on Monday for that 4th and hopefully final webinar of this series. This is a website that I'd like you to take note of. Of course, CDC and NHSN are our definitive experts, so the CLABSI material from today's presentation is taken from here, and also the slides from the 2016 live training. This is very similar to the last 2 presentations where there's a lot of information and a lot of slides. And we know that, and we've done that on purpose so that this serves as a wonderful resource for you all to keep for the references and the information that's contained within these slides. So the first webinar that we've had, we did review the surveillance changes and updates, all of them for 2016. There's a couple that I just wanted to highlight again for the CLABSI surveillance, just to make you aware that bacteria like Blastomyces, Histoplasma, and the rest of them listed here that are mainly community-associated and they rarely cause HIIs are no longer used to report laboratory-confirmed bloodstream infections or LCBIs. Also, they've added an exclusion for documentation of a patient suspected or observed in accessing their lines. So if you do have that, you would note that and document that a BSI was observed after tampering.
Please continue to hold while we do reconnect Deb Smith.
Hey.
Deb Smith has rejoined.
Hello, everybody. This is Deb. I am so sorry for that delay. I don't know what happened. My phone totally shut off. So it's living in rural Virginia, I guess is what it is. So we will just continue on here. Can everybody hear me? Maybe just type in.
We can hear you. We can hear you, Deb.
Okay, wonderful, wonderful. Okay, well, we're going to continue on here with CLABSI key terms. So just a couple terms that we need to know to do this presentation today, and many of you have been working with these, so I'm going to go through them really, really quickly. The date of event for a BSI is the date when the first element was used to meet the LCBI criteria, and the first time that it occurs within the infection window period. The infection window period being the 7 days that includes the date of event, 3 days before and 3 days after, and the repeat infection time, which is a 14-day time period during which no new infections of the same type are reported, and that begins with the date of event as day 1 of that 14 days. So that is the one that during that time you would not be calling another bloodstream infection. You would be adding any new organisms to that the primary bloodstream infection. Primary bloodstream infections are laboratory confirmed bloodstream infections that are not secondary to any other infection at any other body site. So that primary bloodstream infection is what's used to create a bloodstream infection repeat infection time, or RIT. I have a quick example of that here. So in this case, the patient was readmitted after discharge and a central line was placed. They came in with fever, pain, nausea, but the blood cultures were no growth. On the 13th, 3 days later, they did a second set of blood cultures that was growing E. coli. So that's where you start your event. So it's 3 days before, 3 days after. So that date of event being the 2/13, the infection window is from the 10th to the 16th, and you would begin your repeat infection time on the date of the blood culture, so that would go from the 13th to the 26th. Just as an aside here, you never have a secondary bloodstream attribution period for a laboratory confirmed bloodstream infection. That is used for other infections. So a secondary bloodstream infection, according to NHSN, is considered secondary. First, you would need to meet the definition for an NHSN site-specific infection like a UTI, pneumonia, or an SSI. The blood specimen would need to contain at least one matching organism to that site-specific specimen, or the blood specimen is used as an element to meet the specific infection criteria. So in either case, it has to be collected during the secondary BSI attribution time. Now, this is just a list that you can find in the NHSN website of those infections that you can use blood for as a criteria for the infection. And then just because we did mention about the matching organisms, I want to make sure everybody realizes that matching organisms are genus and species the same. So if you have blood and urine with Enterobacter cloacae, that's the same. Or if one was not speciated and you have Enterobacter cloacae and Enterobacter species in blood and urine, that would be the same. However, if you had a blood culture reported as Enterobacter cloacae and then a urine culture with Enterobacter aerogenes, that would be a not matching, so you could not consider them the same organism. This is this is on the NHSN website, and the link is there for it, an algorithm that shows you how to call secondary bloodstream infection. For example, if a patient meets criteria for symptomatic UTI and has E. coli and the blood specimen collected during that secondary bloodstream attribution period is E. coli, then you would report it as secondary. And just wanted to say just a little bit about secondary bloodstream infections with VAE, the VAE guidance, and just to make you aware that you can only have a secondary bloodstream infection with a possible VAP, so a PVAP. You cannot use that for a VAC or an IVAC. And on here, this goes into a lot more detail if you click on this link, but just to make you all aware of that. The secondary bloodstream attribution period is actually the period in which a blood culture can be collected to be considered secondary to any primary infection site other than a primary bloodstream infection. And in this secondary bloodstream attribution period, you are actually combining the infection window period with the infection time frame. So the repeat infection time frame. So this can actually be a period from 14 to 17 days. And I'll show you how that works. Because in this example, the patient met the skin criteria 2A for an ankle wound with Staph aureus on the 13th. So that would go back 3 days to the 10th. For the infection window period to begin. The repeat infection time frame would start on the 11th typically because it would be the first day of any symptoms. But in this case, you're combining the two, so this is actually making this a 15-day secondary BSI attribution period. And I want people to be aware of this because that one day can make a big difference if you can or can't call a secondary bloodstream infection, because if you're not calling it secondary, you're calling it primary and could be a possible CLABSI. So with that in mind, let's talk about some key terms with CLABSI. Of course, we all know a central line is an intravascular catheter that terminates at or close to the heart, and not hard, that is a typo, of a great vessel. Great vessels, of course, superior, inferior, vena cava, brachiocephalic, jugular veins. There's a number of those. And the way that you determine that is by confirmation by chest x-ray. You can't just look at the insertion site or the type of device to identify whether or not it's a central line. And also, if you have confirmed by chest x-ray that it is a central line, it will always be a central line. Despite any kind of migration, you still can continue to call it a central line, and you still count it in with your central line days. You do exclude things like ECMO, femoral artery catheters, intra-aortic balloon pumps, impella heart devices, and those type of things are not considered central lines. And a CLABSI then, of course, needs to be a laboratory-confirmed bloodstream infection where the central line was in place for greater than 2 days on the date of event, and with day 1 of counting those 2 days, the day of device placement. And when we're reporting CLABSI and NHSN, we have 3 different choices for our CLABSI criteria. Not much has changed here with criteria number 1. All you need is the recognized pathogen from 1 or more blood cultures, and that organism that's cultured from the blood isn't related to an infection at another site. So you can't call it secondary to any other site. That would be your laboratory confirmed bloodstream infection criterion 1. Criterion 2 just adds the common commensals. So if you do have a common commensal like staph epi or viridin strep or bacillus propionibacterium, something like that, you need to have it cultured from 2 or more blood cultures drawn on separate occasions. They can be the same or consecutive days, but they have to be within that 7-day infection window period. And along with that, you have to have signs and symptoms, fever, chills, or hypertension. And with laboratory 3 criterion, it is the same as 2, except this is for patients that are less than a year old. And then we also have the option of mucosal barrier injury, laboratory confirmed bloodstream infection, or MBI, LCBI. In order to be able to call an MBI, LCBI, you first have to, of course, have the LCBI. The mucosal barrier injury assumes, this is put out there because it assumes that the gut is the source of the colonizing organism and that the laboratory confirmed bloodstream infection is the result of the patient's altered immune status and the gut translocation. Of course, that being said, we would still call this CLABSI if it did meet the CLABSI definitions, but it would be called an MBI, LCBI. The criteria for this is the population that you can use for this MBI is that they are an allogenic hematopoietic stem cell transplant recipient and they have a grade 3 or 4 gastrointestinal graft versus host disease, or severe diarrhea that in an adult is greater than a liter of diarrhea in a 24-hour period, and the onset of that is on or within that 7-day infection window period. Or they're severely neutropenic, and that's defined as 2 separate days with an ANC or total white count of less than 500, and that's also within that 7-day infection window period. So it's very important to know what our 7-day infection window period is. There's also 3 different MBI LCBIs, one with blood organisms that are identified with intestinal organisms. Number 2 is with just viridins, that's any age, and number 3 again addresses those patients that are less than a year old. This is just a partial listing of the intestinal organisms that you can use for an MBI, the gram-negatives and yeast, and of course Enterobacteriaceae that has a number of different ones like Citrobacter, Serratia, Shigella. The full list is on the NHSN website. And when we are counting central line days, just to keep in mind that we do report patient days every day and central line days every day at the same time each day. So you pick a time, noon of each day, you're counting them. And just to remember that, like in this instance, if you see patient A, the line was removed on the 2nd and put back in on the 3rd. So those days continue to count, 4, 5, 6, 7. Patient B, though, where the line was removed on day 5, it was out for a complete day and then replaced again, you would restart that recount on April 4th as day 1. And then location of attribution, there's always a little bit of a question sometimes about that. Once we start transferring patients back and forth, the transfer rule states if the date of the event for a CLABSI is the day of transfer or discharge, or the next day, the infection is attributed to the transferring location. So that also goes with if it's been a discharge, that the receiving facility should share that information back to the transferring facility because that's who would be reporting that. So in this case, when the CLABSI was identified on 3/24, you would go back to the day before for the transferring unit, but there was 3 different units that it was transferred to that day. So in that case, you would use the first unit that it was transferred. So this particular instance, it would be Unit A. There's surveillance tools, just to make you aware of these, to go onto the NHSN website and pull these tools off. They're customizable. There's a tool for collecting your denominator data, and it accounts for special care units and oncology. There's one for ICUs and floors and wards, but it gives you a place to document each and every patient day and each and every line that the patient has. Very valuable tools. There's also worksheets, and this is an example of one of the worksheets. This worksheet, you can document your infection window period. You can document your repeat infection period, put your criteria for calling the infection on. So with that, we did wonder how many people are using these tools that are on NHSN, and specifically this worksheet tool that I just showed you here, which to me seems like it would be really helpful when you're trying to establish those exact days of being able to call a secondary bloodstream infection, for instance. So you'll be seeing a polling question come up, and right there it is. You have 30 seconds, so if everybody would please answer that. How often do you use it? Do you always use it, sometimes use it, you've never used it, or were you even aware that these tools existed? So please answer that polling question, and we will look at that in a couple minutes. I do want to also stress how important it is to make sure that everything that you're counting is correct, that you've got your denominator days absolutely correct, your patient days are correct, because it does actually impact your reporting. And as far as accurate denominator collection goes, in all locations, if a patient has more than 2 central lines, you only count 1 central line day. So on those specialty care units or oncology units where a patient would have both a permanent and a temporary central line, you would count the one with the higher risk, which in this case would be the temporary central line. And also, patients with a tunneled or implanted central line, you start counting that first day that the line was placed or accessed, and you continue to count it until either you've removed the line or the patient was discharged. So you don't stop counting just because you de-accessed the line. There's also the option, and I don't know, I think it was probably available last year too, but the once weekly denominator collecting, where you can definitely reduce your data collection burden. You would still count all your patient days daily, but you can count your central line days 1 day a week, so the same day every week. You could name Monday as the day that you're going to count your central line days. There is requirements for this weekly collection. The first one is that you have to have greater than 75 central line days a month in that unit, and you have to do a validation first before you can use this, which is 3 concurrent months using an electronic versus a manual method for counting. And the difference can only be within plus or minus 5%. So that might be worth some of you all looking into. We are not going to have time for the case study today. I'm not going to go over much of this because our second webinar did go over the TAP report. This slide is to make sure that you always remember to generate new data sets before you pull any data out of NHSN, so that you have the most current data that you could have. There's so many things that can impact your rates and SIRs. If you're having a question about it, think about some of these things. Did you change the number of patient days? Did you add or delete an event? Did you change something in your annual survey? When you're looking at that, this is some places to look for those issues. Make sure that in your reporting plan, all of your locations are active and you've selected the appropriate procedures. Make sure that you've updated the number of beds from the previous year. If something changed, update that in your survey. And that if you've got your medical school affiliation has changed, make sure that you note that too. And then did you generate new data sets after you ran your analysis? So follow this order. Fix the alerts, generate your data sets, and then go on to do your analysis. Quickly, just so that you know about it, we're not going to go over it today, but there are statistics calculators in NHSN that are very helpful for you to compare your data. What I want to ask everybody to make sure that they do monthly and keep on top of this is to look at your line listing and make sure that what you've put into NHSN is what's there. So you go to your analysis section, to your output options, device associated, pick central line, the CDC defined outlet, and you click on your line listing and then modify it. And for instance, you would modify it for looking at January's data. So in this case, this particular hospital pulled theirs, and they have 4 laboratory confirmed bloodstream infections that are documented in NHSN. Go back and make sure that that is correct and that you haven't missed one or documented one erroneously. Same thing for your SIRs. You go through the same beginning sequel, but then you go down to SIR in-plan or all. The in-plan is what you are reporting in plan. If you're reporting anything off-plan and you want to see that, you would do your all CLABSI data. Modify it to the time period that you want to see and make sure that it's correct. Also, before your ITPS, or your quality reporting is due, you want to run that report and make sure that that is correct before that date is set, that it can't be changed anymore. So to do that, you go into the CMS reports, acute care hospitals, pick the CDC defined output, and then for CLABSI, it would be the CLABSI for ITPS. Modify it to this one. I just modified it for quarter 3 and quarter 4 of 2015. And then you'll get your report. This is what CMS is going to see. So make sure that this is exactly what CMS should see, checking your line days, checking your infection counts, to make sure that that is accurate. There's a number of resources on these slides that are great to use. Please use them. And at this time, before I turn the floor over to Carol, maybe Sarah, can you let us know what the results were from the polling questions?
Hi, Deb. So the results of the polling questions were that 3 out of 70 participants always use the worksheet tool. 18 out of 70 sometimes use it. 13 out of 70 never use it. 8 participants were unaware of the tools, and we had about 28 people not answer.
Okay. Well, there is some room for improvement. I'd be interested, if we have time at the end, to hear from those that are not using it, if they think it would be valuable to use it. But at this time, I am going to turn the floor over to Carol Whalen to talk about CAUTIs with us. Carol?
Hello, everyone. Yeah, so what a great overview of the CLABSI reporting, Deb. Thank you so much. And also for providing the quality assurance points that also apply to CAUTI as well. So, there may be some duplication as I move forward with the CAUTI, but you guys are sharp enough to pick that up and know where that's at. So let's go ahead and get started. Again, we have quite a number of slides to go through. This is a plethora of information for everyone to take and use and store and use for a reference tool. So for a lot of the discussion with CAUTI, as was CLABSI, the slides are going to speak for themselves. So as we get started here, we're going to review, what is a catheter-associated urinary tract infection. And I love this diagram of the urinary catheter life cycle. It's a great visual, and I think it helps us focus on improved processes in these specific areas of care when we really look at the catheter replacement, catheter care, the catheter removal, and the replacement. And so catheter-associated urinary tract infection occurs when germs, usually bacteria, enter the urinary tract through the urinary catheter and cause infection. As we know, and just as a quick review, CAUTIs have been associated with increased morbidity, mortality, healthcare costs, and length of stay. The risk of CAUTI can be reduced by ensuring that catheters are used only when needed and removed as soon as possible, that catheters are placed using proper aseptic technique, and that the closed sterile drainage system is maintained and proper daily care is provided with soap and water. Just a quick review about CAUTI and why we're focusing on all this reporting. So are you feeling it yet? It seems like we're being herded, and we are also being herding our own cats, right, in our facilities and in our organizations. We sometimes feel like this when we're trying to get everyone on the same page. Same thing goes for reporting. So when we look at CAUTI surveillance, this is just a quick review. Deb went over all these surveillance definitions in her presentation, but I wanted to just let you know that the intention of this approach, this CAUTI surveillance approach, is to align criteria and definitions to decrease subjectivity while maintaining epidemiology, that word, standardization and clinical relevance. A variety of scenarios to include repeat infections of the same type, concurrent infections of differing types, and pathogen assignment in multi-pathogen infections are addressed in the definitions. So these definitions are really a guideline for us to provide objective reporting and to reduce subjectivity. Okay. So we'll review some of the 2016 highlights and changes as we move forward. When we look at this slide, I just want to remind everybody that the UTI protocol has been updated. There is a visual within the reporting tool. The alert now has been, the defect has been fixed in the electronic reporting form, and so you will get a pop-up box when you try to enter urinary urgency, frequency, or dysuria, making sure that there is a catheter not in place when you're reporting these signs and symptoms. So one thing I did want to mention about retention is that sometimes we see physician notes stating that the reason for a Foley is retention and or a reason for continuation of a Foley is also retention. So it's just a great reminder that we need to stress the importance of daily indication checks in our huddles and in our bundle elements. And what we found, there's a study that's in the AFIC CAUTI implementation guide on page 79 if you guys ever want to look it up. But it's a study of quite a few patients, and the outcome was that there's just unjustified results of excessively prolonged catheters in place for monitoring urinary output. So we just have a lot of work to do in this area, and our reporting is going to be critical to being able to focus on the areas that we need to improve. So when we look at the UTI protocol update, we know that the Candida species are used not otherwise specified, or these other fungi and parasites mentioned here. This is just a reminder. And you can refer to the CDC PSC manual device associated module for this reminder should you need it. I think we're all pretty well versed in this area. So when we look at the exclusions, Deb mentioned these in her previous slide. These are just basic exclusion organisms that are excluded because of the community onset. And one more thing is that, we won't be using the specimens from documented brain dead patients awaiting organ harvest. So when we look at mandatory CMS UTI reporting, we see that there are two basic specific types we're familiar with: the symptomatic UTI, which we call the SUDI, and the asymptomatic bacteremic UTI, a beauty. So both types, if catheter associated, must be reported as part of the CMS CAUTI reporting requirement. The CD1 criterion is listed here, so the patient must meet 1, 2, and 3 of the following. I'm not going to read these to you, but you are fairly familiar with these. You know, they must have an indwelling urinary catheter greater than 2 days. The date calculation is there for you. And then number 2, you know, at least one of the following signs and symptoms. And remember that the suprapubic tenderness is with no other recognized cause, and then again the urgency, frequency, and dysuria cannot be used when the catheter is in place, and you'll get that alert when you try to enter that. And then number 3, of course, is the urine culture with no more than 2 species of organisms. So all elements, again, need to be within the infection window period. CD1B non-catheter associated criterion is similar, except that this is with the patient without a catheter, and so they will not have a catheter in place when we're using this criterion. Again, the number 2 criterion, which is the fever, the tenderness, the post-vertebral pain. Just remember in this particular 1B that if a patient is less than, if a patient is greater than 65 years old, fever is not a symptom that we can use. So I just wanted to bring that to your attention. And then again, the culture criteria remains the same. So if you're doing any off-plan reporting, if you're not doing any off-plan reporting, you might consider doing some begin to look at doing some off-plan reporting because when you do IDEA UA earlier, depending on the situation, you may be able to prevent attribution to a CAUTI. Okay, so when we look at CD2, this is your less than 1-year-old criterion. Of course, when you look at this patient, they may or may not have an indwelling catheter. So just remember, if it's not in place, it's a UTI, it's a non-catheter associated, and it has to meet that criterion. So there are some additional signs and symptoms for this young patient that you'll want to note there, being apnea, bradycardia, lethargy, and vomiting. Again, they do have to have the urine culture with no more than 2. Okay, so then when we move on to asymptomatic bacteriemic UTI, a beauty criterion, we know that the patient must, again, meet 1, 2, and 3. And remember, this is with or without an indwelling urinary catheter, may have no signs or symptoms in CD1 or 2. According to age, you may have someone who's 65 years of age or older with a non-catheter associated that may have a fever and still meet the A-beauty criterion. So just heads up on that. And then, of course, you know, your definitions of the indwelling catheter also apply. So urine culture, they have to have that, urine culture, positive urine culture, and then a positive blood culture with at least 1 matching bacterium to the urine culture, or meets the LCDI criterion 2 without a fever, and matching common commensals as Deb described for central line, it's in the urine. So all elements of the A-beauty criterion must occur during the infection window period. So calculation is critical to that. So when we look at reporting key concepts and we look at urine culture clarification, just take a look at this list. This is a good checklist for you to keep handy. If you're the person who's entering the data, this is just to make sure that you're getting accurate and reliable data entered into the tool. So we'll go over these now, but just be sure you review this and you're very familiar with it and keep it handy. So reporting key concepts. So in the handout for the webinar today, we sent a copy of one of the tools, the worksheet generator, that is very useful in making sure that your data is accurate and reliable. And I know that in the polling questions, we had about 3 people out of the 70 that said they were using some of these tools. So I think we have some opportunity here to, perhaps begin to use some of these tools that help us be successful in accurate and reliable reporting. So the key concepts Deb went over, and I think the important thing to note here with this CAUTI portion is you do not change the catheter association during a reinfection time frame. So a non-catheter association is a non-catheter association. Do not change it. Okay. Here's an example of the major versus specific type example. Even with CAUTI, you know, you have your skin and soft tissue. You may be able to have two of those types of infections during a 14-day period, but with UTI, you can only have one or the other. You can only have a SUDI or an ABUDI. You can't have both. And then on discontinuing and reinsertion, this is the same concept with CAUTI as it was with CLABSI. You know, if the Foley catheter is discontinued and a full calendar day passes before the Foley is reinserted, then the day count for determining the catheter-associated UTI begins anew. So otherwise, the day count continues from the previous catheter. So here's two really good examples that you can use if you're teaching or you just need a quick reminder whenever you are reporting. Again, we're looking at location and attribution, which is the same concept with CAUTI as it was with CLABSI, and Deb made a very good examples of attribution. Here's four more examples of attribution should you have a question. So on this particular example here, we see that in the last one there's an example of transferring between multiple units, so it may be helpful for you to have as a reference. Remembering the transfer rule, if the date of the event of the UTI is the date of transfer and discharge, or the next day the UTI is attributed to the transferring, discharging location or facility. And the point I want to make on that is that when you're looking at present on admission, if you're trying to attribute to present on admission or to an HAI, be sure and remember your transfer rule, because if the transfer rule comes into effect, then it will not be a present on admission. Okay. Reporting common misconceptions. So here are about three of the most common misconceptions about reporting. And we want to kind of go over these three, which is a fever and then a positive culture being present on admission, and then UTI signs and symptoms being present on admission. So when we look at these misconceptions around fever, when a patient comes in and they have a fever and a positive urine culture and pneumonia, sometimes we think, well, they've got pneumonia and that's the reason for the fever. So fever and hypothermia alike are nonspecific symptoms of infection, and they cannot be excluded from the UTI determination simply because they are clinically deemed due to another recognized infection. When we look at let's see, this misconception on a positive urine culture on admission. When we look at this example here on 8.2, we see a positive urine culture during the POA time frame is noted without UTI signs or symptoms in the infection window period. It is not an event, therefore it is not POA. On 8.9, a positive urine culture is noted. On 8.10, a fever later during the hospitalization is noted. This meets criteria and occurs in the infection window period and is an event. This does not rotate back to the positive urine culture on admission. Okay, and then when reporting signs and symptoms present on admission, remember that UTI signs and symptoms must be accompanied by a positive urine culture within the infection window period, and the date of event must occur within the infection window period. So the example shows a patient admitted on 8.1 with the UTI symptom of suprafluid tenderness, which can't be used because it does not occur in the infection window period. The infection window period is not set without a urine culture, and since no urine culture was obtained, there's no positive result. On 8/11, urine culture sets the infection window period. The 8/10 UTI symptom of suprapubic tenderness can be used because of the urine culture was positive and because it occurs within the infection window period. This meets CAUTI, and the date of the event is 8/10. Okay, I think Deb did a great job of going over the surveillance tools, and so I think that all of these tools and these links to these tools are located in the resource section of the slide deck, and the black arrows here show the location of the Excel document, which is the worksheet, and there's an example there too. So when we look at surveillance, we talk about the tools that we have and the importance of these tools to provide successful reporting that is accurate and reliable. So when we look at these worksheets that are provided, we want to be able to show these to you, help you use them, and see, how they're going to help improve your productivity in reporting. So we highly recommend them, and there's actually 2 tabs at the bottom of the Excel worksheet. If you click on it, you will have one tab for entry and 1 tab for instructions. So I just wanted to point that out to you. You can actually take the worksheet and modify it. This is an example of a modified worksheet that one hospital put together. And if you have any Excel gurus in your presence, then they can actually modify these worksheets to where you can click on the first diagnostic test, and then it would color code your infection window period. Again, this is just an example of how you can begin to progress in your electronic reporting and using these electronic tools to help your productivity and your accuracy. So this is also a good tool to keep at your side. This is investigating a positive urine culture as a positive CAUTI, and I would like to go over these steps with you today. We simply don't have time, but I wanted to point this out to you that it's a step-by-step in determination of positive urine culture and how to investigate. Again, there we go. And this, I guess, of all the tools is one of my favorites, and this is the algorithm or the flow sheet with Sudi and a Booty, and it's a really simple tool to use. It looks really busy, but it's simple to use, and it really helps eliminate a lot of the guesswork or a lot of confusion that comes. So this tool is actually on page 12 of the CDC UTI protocol device module document. So you can print it off and have it at your side, or you can print the slide. It's pretty small on the slide, but you can enlarge it. Again, Deb went over the analysis tools with CLABSI, and it's set up the very same way with the CAUTI analysis. So just wanted to remind everyone that there's great analysis tools. The CDC's put a lot of work in being able to provide quick analysis tools for hospitals to use. So if you're not using them in your IT department or with your IPs and your IC department, be sure and make your analysts, your IT analysts that work with your data available. Let them know that these tools are out there. And, Deb demonstrated the use with the CMS reports and how valuable that can be before your data is publicly reported. So just want to make sure that you know that those same tools are out there for CAUTI. And then just wanted to review quickly entering your summary data, which Deb did as well, and how important that is. And remind you, if you haven't looked at your weekly sampling, you may want to take a look at that. Maybe it hasn't been something you've done in the past, but it may be something that you're ready to move on to. So I think a review of how you're capturing your summary data is good to add with once you're doing your annual report. You can take a quick look at how you're reporting your summary data and see if that's continues to be the best methodology for your institution, as well as your denominator sampling. Just take a quick look at that once a year and make sure that, you're using the best methodology for what's going on in your institution. Okay, and then again, I think this, as we begin to look at the data analysis tools that are out there, this is with the CAUTI SIR. I like the scripting on this particular slide, so if you're an IT who does reporting to various teams and committees and to leadership, the scripting on the side I think may be very helpful to you. During the third quarter of 2015, we identified 10 CAUTIs. Based on the national baseline, 7.167 CAUTIs were predicted, and the SIR indicates that we identified nearly 40% more CAUTIs than what was predicted, and based on the statistical evidence, we can conclude that our CAUTI SIR for quarter 3 is not different than 1. So I think the scripting on it's really good, and it helps people understand better how our reporting is affecting our SIR and how that our SIR definitely impacts what's going on in the payment world. We have about 5 minutes left, and so I just wanted to provide a couple of case studies for you. And again, we're not going to be able to go through these, but I think if you take a look at these slides, then you'll be able to identify the issues with these particular case studies and how they can help you be more accurate on your reporting. So again, we have the supplemental slides that you can see here have the links to the analysis report, to the worksheet generator, to the UTI protocols, to your SIR and TAP reports. There's a lot of information on these slides regarding the TAP report and the CAD calculations, your TAP analysis that was covered in last month's call. Again, some details around the infection period and the reinfection time frame, and some checklists. So your device-associated analysis resource tools, again, those links, additional resources. So you can see why this slide deck would be very helpful and maybe a one-stop shopping when you're looking for something in particular. Just wanted to remind you of the NHSN May 15th, 2016 is the deadline for all quarter 4 data. So the deadlines here are delineated for you in regard to rehab and long-term care, and also the influenza vaccination data. So now we're at time for our questions. I think the evaluation form has popped up in the chat box, and so do we have any questions in the chat box at this time, Sarah or Karen?
And can we have the operator let everyone know how they can call in with a question? Laura?
Certainly. If you do have a question on the line, please press the number 7 or the letter Q on your telephone keypad.
Do we have any questions in the chat box? I think the only thing I'm seeing at this point is, okay. If you're tracking a UTI during a repeat infection time frame that is not catheter-associated, and then CAUTI comes up in the 14-day reinfection period, you would not change the catheter association. You will still go by the original UTI that started the RIT. Thank you for that clarification, Sarah.
Other than that, there were just a couple of questions about getting the slides, so I said that we could just email out the slide deck to all the participants after the call.
Yes, and this is Deb. Also, in a week, all of the call, the slides, the handouts, everything will be available on the VHQC online community also.
Are there any other questions on the phone line?
Cheryl, there is a question in the chat box that just came up.
Okay, let's see here. Okay, from our NISQIP folks are following CAUTI's post-discharge. What is the time frame to be monitored? So if you're doing this for surgery, or also, are you talking about CAUTI post-discharge? Oh, okay, I see it now. Okay, post-discharge. Dan, have we heard anything about post-discharge tracking of CAUTI?
No.
Other than it be, if they're readmitted, then we could track them.
Right. We would have to follow up on that. I don't know if NSQIP has different guidelines or not. I mean, typically we're only looking 48 to 72 hours. I see that's Betsy. I don't know, Betsy, did you want to call in to clarify a little bit, or they do use different criteria? Okay.
Okay. Yeah. So I know that right now the only way it seems that we have to track is if they're discharged and then they're readmitted within readmitted. Then we can track those, but unless we know they're readmitted, we wouldn't be able to do that.
Well, and another important reason to report back to the transferring discharging facility if you do identify an infection within the first couple days of discharge. Like if they're being discharged to a nursing home, that would be one way that it could, be relayed back. Any other?
Hey, Deb, I think there's a question in chat on accessing the line. Do you want to take a peek at that real quick, and we'll wrap it up?
Oh, well, that's interesting. I just wanted to clarify that accessing the line is inserting something into the line. We had a patient that mouthed the line and removed it from their MediPort. Well, I would say that removing the line is manipulating the line. Maybe not just, but the fact that they removed the line would be, because it's tampering with or manipulate. It does say tampering with the line. But, we could send that to NHSN to get clarification. Sarah, do you remember anything more specific?
No, I don't. I think we would have to look into that further, but I don't know that that's in the guidelines anywhere. I agree with you that it's just general tampering.
Okay, everyone. Well, we are at the top of the hour. If there's no more questions in the chat, and I think that Betsy did reply about a 30-day time frame, and she'll research and do some more and get back with us on that. But if there's no more questions on the line, there's no more questions in the chat, then we'll follow up with you guys with the recording and with any unanswered questions. And Deb, do you have anything else in closing remarks?
Just thank you, everyone, for taking the time to join us. We really appreciate the support.
Yes, we do. And so from VHQC Moving Network and Virginia, we thank you guys and have a good day.
Thank you.
Thank you. This does conclude today's teleconference. We thank you for your participation, and you may disconnect your line